Yeah, good morning, guys. Our topic today is about assessment of pain. If you are going to see the first slide, we have the pain assessment tool. So you must be familiarized with this one because if you will be having your duty in the hospital, you will be able to find these one sheets in the patient's chart. We have the pain assessment tool, so that is numbered from 0, 1, 2 up to 10. So meaning if the nurse will mark 0, there's no pain. From 1 to 3, there's mild pain. From 4 to 6, there's a moderate pain. And then 6 to 7, we have severe. And then from 7 to 9, we have the description of very severe pain. And 9 or 10, that is what we call as the worst pain possible. So this is the time when the patient, when you're going to interview, almost they will say that they are dying because of the pain. So here, in the assessment of pain, there are intended learning objectives you will know. You must know how to define what is pain, what are the categories of pain. You will be able to discuss the effects of acute and chronic pain after we have lectured this topic. You will be able to differentiate between what are the types of pain, able to describe the neurophysiology of pain pathways, and what are the factors that influence the response to pain. And then you as a nurse working in the hospital, you should know how to perform the pain assessment. And then after that, applying the nursing process, you will be able to do the management or the implementations of pain. And on the other way around, you will be able to discuss what are the pharmacological and non-pharmacological pain management. So first, we are going to define what is an assessment of pain. According to the International Association for the Study of Pain, they define it as unpleasant sensory and emotional experience associated with actual or potential tissue damage. A nurse and leader in pain management field has more useful definitions for nurses. We in our field, we define pain is whatever the person experiencing it says it is and exists whenever he says it does. So what are the categories of pain? So first we are going to classify pain. 1, we are going to identify the source. Second, the referral. And then third, the duration. First, what is the source? There are sources. The first is we called it that as nociceptive. It is usually acute and may be categorized as cutaneous or superficial, that involves the skin or the subcutaneous tissue. Example, the sharp pain by knife injury. And then we have the deep somatic pain under nociceptive as source. It is a diffuse or scattered and originates in tendons, ligaments, bones, blood vessels, and nerves. So if the patient will complain of pain, and then you'll be able to assess it came from the source visceral pain, they will say, it is a poor localized and originates in body organs. Example, the thorax, cranium, and abdomen. We have also what we call as neuropathic pain. What is this? This is the result from an injury or abnormal functions of peripheral nerves or central nervous system. Its duration is short and described as burning or stabbing pain. We have the other one, the psychogenic pain. It is unknown the physiologic cause. Now we have the referred pain, the second. What is this? It is perceived pain in an area that is distant from its point of origin. The pain in myocardial infarction or heart attack is referred to neck, shoulder, or arms, often the left arm. So the third classification of pain is we have, or categories of pain, we have the duration of pain. So under this, we have the acute pain. This is generally rapid in onset. It varies in intensity from mild to severe and may last from a brief period up to in a period less than 6 months. Example, the postoperative pain. Or if you have viral infections, you will be able to manifest sore throat. It is resolved after underlying the cause. We have the chronic pain. This may be limited, intermittent, or persistent, but this lasts for 6 months or longer and interferes with normal functioning. We have the chronic pain. This is often perceived as meaningless and may lead it to the host to be withdrawal, depressed, anger, frustrated, and dependent. So most of our psychiatric patients now they suffered from this chronic pain. So what are the effects of acute pain? We have the neuroendocrine response to stress. This will increase the metabolic rate. It will increase the cardiac output. And then somehow it will impair the insulin response. It will increase the retention of fluids. It will increase the risk of physiologic disorders and decrease deep breathing and mobility. So those were the effects of acute pain. Now, if there's acute pain, we have also the effects of chronic pain. This will suppress the immune function. There will be resultant of increased tumor growth, depression and lack of motivations, and then we have anger and fatigue, which are the effects of chronic pain. So the question is, what are the physiology of pain? There's a mechanism or process of pain that involves 4 stages. Number 1, we have the transduction. We have the transmission. The third, we have the perception. And then fourth, we have the modulation. First, let us discuss what is transduction. This is the activation of pain receptors that involves conversion of painful stimuli into electrical impulses that travel to the spinal cord at the dorsal horn. When a pain threshold has been reached and there is injured tissue, substances that stimulate the pain receptors called nociceptors are released. These pain receptors can be stimulated by serotonin, histamine, potassium ions, acids, and some enzymes. So, if transduction happens, the question is, if there's pain, what is pain threshold? This is the amount of pain stimulation that person requires before feeling of pain. So we have also the pain tolerance, the highest intensity of pain that the person is willing to tolerate. So every individual patient has different pain threshold and different pain tolerance based on the types of pain that they have experienced. So if you can see the slide, we have the needle prick the skin. So there is an amount of pain threshold, there is an amount of pain tolerance every individual will experience. So the next is we have the transmission of pain stimuli. There are 2 separate pathways that transmit pain impulses to the brain. The first is we have the A delta fibers. This will carry the fast pain, example the sharp pain to the spinal cord. And then second, we have the C fibers. This will carry the slow pain, chronic pain, impulse to the spinal cord. So we have the diagram of how the transmission of pain. So from peripheral nervous system to the central nervous system. So we have if that came from the nociceptors, it will transmit through the fiber going to the inhibitory interneuron. We have the second order neuron, and then the strong signal sent to the thalamus. So the thalamus will be the one to make interpretations and give up the meaning. And then we have the unmodulated pain. So from nociceptors, it will go to the fiber, and then it will go to the inhibitory interneuron, down to the second order of the neuron, and then weak signal sent to the thalamus. So here, if the pain is from the skin mechanism receptors, it will go directly to the A fiber and then go to the what we call as inhibitory neuron, but go straight to the dorsal column. We have the peripheral nerves transmission of action potential. So if you have studied anatomy and physiology, go back to the neuron system. We have the myelin sheaths, and then we have the what we call as chemical receptors. Now we have the Na plus or sodium, we have the A, we have the A5, and then we have the C, and then down to the peripheral nerve, going to the spinal cord, and then try to familiarize with the anatomic structure of the brain. Okay, this is the anatomic structure of the brain that involves pain stimulus. Now we have the what we call as the pain tracts, and then going up to the reticular formations, and then we have the slow pain fiber, then down to the intralaminar nuclear thalamus, and then this thalamus will be the one to give the interpretations of how is the pain, what we call the scale. And then of course, if you feel pain, say for example, if you feel it's hot, so the brain through the thalamus will give the meanings and then send signals to the motor neurons, and then let your muscle move, and then your skeleton move, and then you are going to retract the part of your body in which you feel it's hot. So that is how it works. So we have the pain reception or pain perception. This is the point at which the person becomes aware of the pain. So the pain stimuli is transmitted along the nerve fibers. It will enter the spinal cord and ascend to the cord to the thalamus reticular formations. So conscious perception of the pain occurs initially at the brain stem and thalamic level. Interpretations and localizations of the pain is thought to occur in the cerebral cortex. This is what we have said, right? Giving up meaning and interpretations, and then the motor neuron systems will do the move of the muscles, and then the skeleton will move the whole part which is affected. So if it's hot, if it's cold, if it's pain, you are going to retract, and then you are going to move away from that certain area. So we have the fourth, the modulation. It refers to the activations of descending neural pathways that inhibit transmission of pain. So here, the pathways are described as descending because they involve neurons originating in the brain stem that descend to the dorsal horn of the spinal cord. So from here, the descending fibers release substance that produce analgesia. So analgesia meaning it will relieve pain by blocking the transmission of noxious stimuli. So the pain modulation is the result of the effects of endogenous opioids, also called as enkephalins and endorphins. So pain is modulated through these chemicals, enkephalins and endorphins. So from this diagram, we have the mechanism of pain. If you are going to trace that up from the down, from the peripheral nociceptive, say for example, if there's an injury happened to your hands, now it will be emitted or transmitted through the peripheral nerve down to the dorsal root ganglion, to the dorsal horn, and then to the brain, the thalamus, and then giving of the interpretations, how much the intensity or scale of that. So it will go to the descending pathway, and then of course there will be a behavior done by a person. So from here in this diagram, the what we call as we have the activate, we have the release, we have the stimulate. So say for example, if you are going to trace up, now try to see in the diagram from the upper part, if there is what we call as tissue injury. If there's tissue injury, normally it will cause inflammation. So inflammation, if you are going to assess the patient's skin, there will be what we call as warm, swelling, redness, okay, color, or another manifestations if it will not be prevented. So from here, it will produce inflammation to the cells. So the leukocytes, the mast cells, the lymphocytes, the macrophages, and the platelets. So it will release the cytokines, nerve growth factor, the prostaglandins. We have the thromboxans, we have the leukotrienes and serotonins. So these are, now this will release the neuropeptides, activate the neuropeptides. Then somehow, because of this, it will produce the simulation of excitations. So the sympathetic neuron system will be stimulated, and then the response of pain will happen or transpired on this process. So we have the what we call as gate control theory. Now this is part of the pain. So at least you will know this theory, so you'll be able to analyze, you'll be able to do an outline. Now how does pain going on in the human system? So we have the anatomical structure of the gate control theory. We have the dorsal horn. We have the large diameter fiber. We have the small diameter fiber carrying the pain impulses. And then we have the spinal cord. So if we are going to close the theoretical gate, we have the large diameter fiber carrying non-pain impulses to brain, and then we have the small diameter fiber carrying the pain impulses. So this is how the schematic diagram of the gate theory of pain. So from here, now we have the noxious. Now these are experiences by our patient suffering from pain. So stimulus because of the hot flame, or because of the knife injury, the puncture, the cut, or we have the destructive stimulus because of if you are going to rub always your skin, massaging, applications of heat, and others. So this will go to the what we call the small peripheral nerve fibers, and then go to the nociceptions, and then we have the attenuated pain signals going to the brain, and then if that's painful, there will be distraction. So that's why it was called as gate theory. So that signals, and then down there, if that's massaging, if that's rubbing, now large peripheral nerve fibers will be stimulated, and then going to the gate control theory. So there will be distractions of that. So for us now in the field of health practice, healthcare professionals, students, patients suffering from pain, especially if that's 7 to 9, it's severe pain. So that will not be eased, that will not be relaxed through independent nursing intervention. So that's the reason now we are going to administer the dependent functions. Now whatever is the pain reliever prescribed by the physicians, now we are going to administer that one in order for now the pain will be distracted. So the behavior of the patients will be controlled, and then to prevent any untoward sudden increase of the vital signs of the patient. So we have the response to pain, as what I have said. Now it will go to the behavioral voluntary responses. What are the specific on this one? So if that's painful, you are going to move away from the painful stimulus. So if that's painful, normally if you are going to observe the patient's face, they're grimaced, they're moaning, they're crying. Now their behavior, they're restless, and then they are protective from the painful area, and then they refuse to move So what are the physiologic and voluntary responses? We have the typical sympathetic responses when pain is moderate and superficial. This will increase the blood pressure, it increases the pulses and the respiration of the patient. So there will be pupil dilation, muscle tension and rigidity, color, peripheral vasoconstriction, or it will increase the adrenal output, and then somehow this is common to patients suffering from diabetes mellitus. Now there will be increase in blood glucose. So what are the typical parasympathetic responses when pain is severe and deep? So these are the typical manifestations you will be able to observe to patients suffering from pain, no, parasympathetically, which is deep and severe. They will manifest nausea and vomiting. They will be fainting or unconscious. There will be decrease in blood pressure, decrease in pulse rate, rapid and irregular breathing. So if there is parasympathetic responses, there should be psychological responses also. So this will lead to the behavior of the patient, exaggerated weeping and restless. They will have the withdrawal, suffered anxiety, depression, fear, and anger. They will have anorexia, whatever food you're going to offer, they will not eat. And then it seems that they are very fatigued, they're hopeless and powerlessness. So this is the time they're going to complain, they're going to say, why me? Why? Okay. So next is we have the what we call as factors that will influence the response to pain. What are the factors that will influence the response to pain? So we have the culture, we have the family, gender, and age variable, of course. If that's a child, if that's an old one, if that's an adolescent, okay, it varies how you are going to respond with pain. We have the religious belief. Third, environment and support people. Fifth, anxiety and other stressors. And then we have the past pain experience. So if you experienced that pain before, somehow it will mitigate. No? You will not. You'll be accustomed with that one if you have always experienced that pain. So if you're a nurse, how to perform pain assessment? This will include getting the history, doing physical examinations as with any assessment. Always begin with a history since pain is subjective, okay, in nature. The history component of the pain assessment is the most important. You're going to assess pain as fifth vital sign. Now we have 4 vital signs, right? Blood pressure, temperature, pulse rate, respiration, but when you're going to manage pain, you're going to consider this is the 5th vital sign, pain. So in performing health history, you are going to do self-report. What is this? This is the most accurate indicator of pain. Because pain is subjective in nature, the patient's health history provides the best assessment of pain. The history also allows you to assess past experiences with pain, effective pain treatments, and the effects pain has on every aspect of the patient's life. So the next is you are going to assess with the biographical data. Under this, we have the patient's age, the ethnicity, religion, then the way the patient perceives what is pain, the behavioral responses to pain, the gender influence her or his perception of pain. So basically, now according to study, when it comes to pain, women were more tolerant to pain than men. So patients' occupations may be a direct cause of the pain, such as back pain related to heavy lifting and presence of pain may prohibit a return to work. So this is common to men. Okay, you know, men, that is the head, the patriarch of the family. Whatever is the difficult thing to do, the heaviest thing to do, you are going to do it first. Then next is you have in performing pain assessment, you are going to find out the current health status, the onset, when did the pain begin, the location, where does it hurt. You're going to ask the patient, can you point to where it hurts? You're going to ask the patient, how long does it last, the duration? And then you are going to find out the characteristic by asking the question, what does it feel like? Identify the aggravating factors. Does anything make it worse if you are going to move like this? Do you feel pain more? So we have the radiation. Does the pain go anywhere else? From left to right, from down to up, up, down, or something? So we have the treatment. You are going to ask, did anything make it better? Are you taking pain medications previously? Last 3 days, last 2 weeks, or 1 week? And then next is we have, you are going to find out, this is the time you are going to know the scaling, no? The pain intensity rating scales. So we have the visual analog scale, or VAS. No pain to worst pain. And then we have the numerical rating scale from no pain, which is 0 up to 10, which is worst pain imaginable. So we have the categorical scale, 0, none, if 1 to 4, mild, moderate 5 to 6, then severe pain from 7 to 10. So basically, in the hospital setup, now we are using much more in numerical rating scale or categorical scale. So if you are going to assess while asking question the history and current status of your patient, you are going to be watchful because this is the objective. The face, now you can observe the face of the patient when it does no hurt. Then 2, if hurts just a little bit, if the patient will say hurts a little bit more, and then you can observe their behavior. Number 6, if hurts even more. 8, if hurts a whole lot. And then if they will say, almost I died because of this pain, that's number 10. So we have the brief pain inventory. Now you are going to shade the areas of the worst pain, then put an X on area that hurts most. Now you can do this if you will be in the hospital, and then you will be in the nurse stations, and then doing the shading. Now, because there is what we call a schematic drawing of the person, of the patient there, and then you are going to shade what part. Now, if it's there, the back, clavicular, if it's in the butt, or if it's in the ankle, whatever part in the body. So, in pain assessment, you are going to study also the what we call as the past health history. So, what causes of pain? What is the past and present medical problems that may influence the pain and its management? Are there any psychiatric illnesses and chemical dependence? The past and present pain management strategies done. Past experiences with pain. So you're going to identify whether it's chronic against acute pain. So family history, you are going to find out whether this family has sickle cell anemia or any cancers, because this particular disease, now patient is constantly suffering from pain. So you are going to review the systems, this problem, because one system is being affected, and then it will transmit, it will evolve, and then it will influence other system. So you are going to do physical examinations by observing. Now, in the last discussions that we have enumerated what are the physiological responses, what are the behavioral responses. Then, of course, following the nursing care plan format, nursing process. So, after the assessment, you are going to formulate nursing diagnosis by following the NANDA problem format. So, in making nurse diagnosis, you are going to formulate what's the problem, connect that with the cause or etiology, then what are the characteristics or the symptoms or any evidences. So that is a simple nursing diagnosis you are going to do. So mind you, students, now you are going to be smart. Now specific, measurable, attainable, realistic, because in finding out problems of the patient, a lot of problems arose, but you are going to prioritize the most problem of the patient. So one by one, line upon line. So these are examples of the nursing diagnosis related to pain. So when you are going to do planning and implementations to patients suffering from pain, the nurse identifies nursing interventions that will assist the client in achieving the overall client goals or preventing, modifying, or eliminating pain. So the purpose, client will be able to partially or completely resume usual daily activities and be able to cope more effectively with the pain experience. So another one is you are going to establish a trusting nurse-patient relationship. So how to do this? Of course, now you must be truthful. Now you must manifest privacy to the patient. Now what is being told to you, now only you and the patient will know. So manipulating factors affecting the pain. So in order for you to alleviate or relieve the pain experienced by the patients, you are going to remove or alter the cause of pain. So some techniques you are going to do. Now you are going to tighten the binder, distend the abdomen or bladder by helping patient to evacuate or pass flatus. So altering factors affecting pain tolerance is that pain is aggravated by fatigue. So you are going to do diversional activities with this. Now you are going to manipulate the bright light into dim light, so it will stimulate patient to sleep well. If that's noisy, you are going to remove that noise. And then if fear, now you are going to spend a little time for your patient and then discuss the nature of the disease in order for his or her fear be eliminated or reduced. So most of all, you're going to provide a quiet environment. So we have the non-pharmacologic pain management to patient suffering from pain. So we have the technique of distraction. You are going to distract the patient's attention away from his pain. So for children and in mild adults pain, by using the following technique as visual, auditory. So this is the time you are going to give a soothing music for them, or you are going to apply massaging or rubbing, so to project or to eliminate distractions to pain. Music therapy, imagery. So if that's a kid, you are going to give them imagery or pictures for them to relax. Acupuncture, cutaneous stimulations. We have the simple therapeutic touch to be done. So for the pharmacologic pain management, of course, this is what we call as dependent intervention by nurse. We are going to rely with the prescription of the physicians, and then we are going to administer to relieve the pain of the patient, especially patients suffering from cancers or sickle cell anemia, any other disease that pain constantly exists. There are three general classes of drugs used for pain relief. We have the opioid analgesics, we have the non-opioids, and then we have the adjuvant analgesics. So this is the time you are going to use your pharmacology 1 and 2 courses. Study, now we have drug study on this one. So when you will say opioid analgesics, these are analgesic used in management of moderate and severe pain. So when you say moderate and severe pain, if you are going to apply the numeric scale from 7 to 10, if the patient will be in 7 to 10, this is the time, no? You are going to anticipate doctor will order opioid analgesics. So we have the non-opioids. It is a drug choice for mild and moderate pain. The drugs contraindicated in patients with bleeding disorders. Now example, narcotic, morphine, and codeine. So we have the examples of adjuvant analgesics. What are these? Medications used to enhance the effect of opioid by providing additional pain relief in home or acute care settings such as diazepam. So this is done now when the patient will be home managed mental riding, and then they were discharged, and then there's what we call as continuous pain medications at home. So most probably adjuvant analgesics will be given to them. So we have the patient-controlled analgesics. We have the this is used in acute and chronic pain, as in delivery, trauma situations, and cancers. And then, what are the advantages of this one? I will give you one or two. Now, consistent analgesic blood level is maintained rather than by IM. And then the absorption is faster than IM. Patient was satisfied. There is improved pain relief. Patient tend to use less medications because it is self-administered. So if pain can't be managed by any pain medications, this is the time there will be surgical management of pain. Now, chemical interruptions of a nerve pathway affected by injecting a local anesthetic into the nerve. So it involves the pain conduction pathway or neurectomy. So meaning there's what we call as removal or cutting of a particular nerve. So to block the pain. So for evaluation, because pain is subjective experience, most evaluative data collected are obtained by questioning the client about specific information taught about level of comfort, level of energy and sleep pattern, and whether modifications in activities or the use of non-invasive strategies were helpful. So class, this is the last concept nursing process evaluation. So pain. So further from the discussions that I have done, now we have the references. If you have time, don't just rely on the PowerPoint presentations and the video lectures that you have. Now you can go to the hybrid library, internet, and then browse, study more in order for you to become effective, more, and very efficient nurses someday. Good luck. Bye-bye. That's all. Thank you.